Hello, my name is Jen. I am an occupational therapy student at Gannon, or OT. Today, we're going to talk about a case study. Our case study today is about Mrs. X. She will be referred to as Mrs. X to maintain her privacy. Mrs. X has sustained an amputation. We'll talk about her more later. The main purpose in this presentation is to discuss some theories. I have chosen two theories that I think would be very appropriate for her particular case. Okay, so the first thing I'm going to run through is my definition of what occupational therapy is. Located on my slide, I have some bullet points that I've taken off AOTA's website. AOTA is the American Organization of Occupational Therapy. What I think, honestly, that OT is, and to me, it's just a very client-centered therapy. Each different intervention plan is written specifically for the client and what the client wishes to achieve. This is great because a lot of therapies, like physical therapy, for instance, when someone, tears an ACL and they have surgery, the recovery process is the same for every ACL tear. They have a certain goal of, being functional and the mobility and all that, but the recovery is the same. For OT, you could have a client who wants to do any occupation, and any occupation can be whatever they choose it to be, which is really great, and it makes the possibilities endless for what you could be helping someone recover in. The biggest thing is that we set goals to achieve everyday activities or activities of daily living. So by definition, activities of daily living would be, okay, so they need to be functional in cleaning and preparing food, eating, using the restroom, dressing, those sort of things. So textbooks wise, it would be the activities of daily living and the everyday activities. But it can be expanded into almost any occupation or activity that the client would ever want to do. And that's huge. And we use goals, you set goals and you achieve goals to hopefully achieve an overall goal of whatever occupation or activity your client wants to achieve. Okay, so now we're going to talk about our client in our case study. Our client is Mrs. X. She's a 67-year-old widow living in an assisted living facility. She's resided in this facility for roughly 2 years. She has a lower extremity amputation. Her amputation is from circulation complications due to diabetes. Her amputation was located below the knee, and she's roughly had her amputation for 2 years now. She's very independent in donning her prosthetic, and her ambulation skills are also independent with her adaptive equipment, which in this particular case is her wheeled walker. Now, Mrs. X's biggest limitation has been her emotional adjustment to her amputation. She's had much difficulty emotionally and cognitively dealing with her amputation. She frequently cries, and she gets very angry at other residents and the staff. And occasionally she even resorts to isolating herself in her room. Previous to her amputation, Mrs. X worked as a high school art teacher. She had won a number of awards for her teaching. As well as receiving awards for her teaching, she had also received a number of awards for her own personal creations. She has, however, done no creative works since her amputation. She also refuses to engage in activities in the facility. She has been referred to OT for leisure pursuits and improving socialization and communication skills. This includes trying to engage and promote her participation in activities at the facility and improving, hopefully, her mood and adjusting to the way she interacts with the staff and the other residents. Okay, so now that we've explored Mrs. X's case a little bit and found out a little bit about her, we're going to explore the theories that I have selected to base our intervention off of. The first theory that we are going to talk about is the intentional relationship model, or the IRM. On my slide, I have included a quote from the textbook Conceptual Foundations of Occupational Therapy Practice by Gary Kielhofner. I will have that in a reference in the back as well. I have supplied a quote that is an overall definition of what the IRM is. The IRM was created by Renee Taylor, 2008. So what it basically is it interviews the client and it gets to know them and their characteristics. The two main characteristics that are important in getting to know in your interview are situational characteristics and enduring characteristics. Situational characteristics are basically the characteristics that a client will expose when something happens. It's how they react to things. Enduring characteristics are how the person is as a whole all the time, the lasting characteristics. Now, as we get to know these characteristics, it will help us better judge interpersonal events. Interpersonal events are the events that happen during therapy. So once we get to know our client, we will be able to read our therapy and our sessions a little better. As well as getting to know our client a little better, this also helps us choose therapeutic modes. Therapeutic modes are used to interact with our client. If we choose the correct ones, we will get the best results when interacting with our client. The 6 therapeutic modes in occupational therapy are advocating, collaborating, empathizing, encouraging, instructing, and problem solving. Once again, the intentional relationship model, or the IRM, is Renee Taylor's theory from 2008. The model of human occupation is another theory that I have chosen to go along with Mrs. X's case. It is also referred to as the MOHO. Gary Kielhofner is the creator of the MOHO. He is also the author of the textbook that I have referred to throughout the presentation. The MOHO became the first client-centered model by looking beyond clients' impairments or disabilities to other client-related factors affecting occupational performance. Within these factors, there are actually 3 subcategories. They include environmental factors, volition, and capacity for performance. Environmental factors include what the client is taking in from the environment, which is input, and what the client, how they respond to it and what they are putting out, which is their output. Now, the next part is the volition. Volition for the client would be their motivation to perform the task. If a client is not very motivated to perform a task, the chances of them doing the task well are not that great. The more motivated they are to achieve the task, the greater the results will be. The last part of the MOHO is the capacity of performance. Sometimes we have to gauge whether a client is even able to perform the activities they would like to do. Here lies whether they are able to fully achieve an overall activity or if it has to be modified or adapted so they could once again perform the activity. Another thing that goes along with the MOHO is that using these 3 categories or these 3 sets of factors, we then choose occupations that are personally meaningful to the client. We then use these occupations in intervention to reach the goals. Usually, the occupation is the overall goal, but the client will be much more motivated to participate and actively engage in an occupation that they really want to do. So the MOHO puts all of those 3 factors together to go towards a goal of an occupation that a client really wants to do. And this really helps because if the client really wants to do it, obviously they will perform better and they will be excited to do it, and they will actively engage in therapy to reach their own personal occupation versus one set by a therapist which they may not care about. So, client limitations. Our client limitation is obviously, a little ambulatory. Although she is independent, her mobility is not too much affected with her adaptive equipment, which is a wheeled walker. Her biggest limitation is her emotional adjustment to her amputation. Since her amputation, she has not participated in activities that she used to enjoy that made her happy. So if she's not necessarily happy, she probably will not interact with others or react to events well. Now, the intervention to hopefully improve on her mood, which I think would improve her participation in leisure activities, her socialization, and her communication skills, would be to implement creative works into her daily routine. And obviously, we would use these creative works in therapy to try and improve her mood. Once her mood is improved, this would hopefully lead to better interactions with her other residents and her staff. Hopefully, we would try to achieve more participation and engagement in activities, particularly leisure activities, which were in our goals. And by using creative works, we would be using an occupation that was personally meaningful to her. She was an art teacher, and she was very good at what she did. She won awards for teaching art, and she won awards for doing her art. So, we could also even encourage her to maybe even teach others in the facility art, which would work on her leisure activities and participation. We would also hope to improve her mood, which would oftentimes improve her interaction with others, which would be the communication and socialization skills. Overall, Mrs. X was not really in therapy for a physical disability, although she was in therapy for an emotional disability that she had suffered from her amputation. So, with this, we would use the IRM and the MOHO to one, get to know her on a better level and pick a therapeutic mode that would encourage the best results, and two, analyze her motivation, her capacity to perform, and her environmental factors in in an occupation that she really enjoys and has meaning to increase her mood and achieve our goals. Now, our goals were leisure activities, which would be creative works for her since she was a teacher and she really enjoyed that, and improving communication and socialization skills. Improving her mood would hopefully improve her interaction with others. So, overall, occupational therapy was not performed for a physical disability this time, but for a side effect of the physical disability. And here are attached the references I've used throughout the presentation.